Thank you for this wonderful opportunity. I always find it provocative just listening to the other speakers and also just understanding the journeys that so many people are on as they try to get better. So I'm going to try to tie in and connect the dots on why an allergy immunology specialist is been invited to a primarily neurological neurosurgery conference with all the complications that could be associated with these structural issues. And so the first question I'm going to pose is, why am I here? And I want to just talk a little bit about the role of the immune system when it comes to maintaining homeostasis, which is simply the process in which the body maintains healthy ranges of factors like temperature and energy so that we can keep moving. So we eat, sleep, drink, and repeat all day long. And while we're doing this in an environment where we are exposed to lots of microbiota, chemicals. Some of them are we need, and others that we don't. And so it is the job of the immune system to kind of recognize what is dangerous, what is safe, and what is dangerous. We have, as Dr. Sloterdijk, a European philosopher, had said, we have an immune system that has been designed to expect injury and then respond to it, and then also coordinate the healing process. And we have a very complicated immune system with two major components. You have the barrier, and then you have lots of different proteins and cells that all have different jobs to do. And why I would like to focus on the mast cells is, unlike most of the cells that you might see in a complete blood cell count, these cells are closely associated to the epithelium of any organ system that's exposed to the environment. And basically, they're the ones that make the decision on whether this is something that's been recently encountered. Is it safe? Is it dangerous? And if it is dangerous, they have the capacity to respond, to contain that danger, and call in appropriate help. So while I try to put the pieces together regarding these structural neurological issues and what Dr. Ashley Cook talked about yesterday regarding the relationship of these neurosurgical issues with connective tissue disorders, I like to kind of bring in the role of the immune system and potentially predisposing to connective tissue disorders and possibly setting the table for the development of these neurological issues. And these are my disclosures, but none of these will be a conflict of interest for this conversation. So I'm not gonna reinvent all the wonderful information that was put forth yesterday and today, but needless to say, there are lots of different types of structural issues that can happen with the central and peripheral nervous system. And as Dr. Ashley Cook had presented yesterday, there is a strong relationship between individuals that have various forms of connective tissue disorders that may predispose them to the development of Chiari malformation, Syringomyelia, occult pelvic cord, Tarlov cysts. And I'd like to talk about the role of the immune system in connecting the dots between the connective tissue disorders and those neurological issues. So this is pictures of Dr. Ehlers and Dr. Danlos, who first described connective tissue disorders in the early 1900s. And interestingly enough, to the right is a picture of mast cells next to nerve fibers within the connective tissue. And although these cells were the first immune cells essentially described in the mid-1800s, we really didn't know what these cells did until the 1900s. So I'd just like to kind of review a little bit about the structural integrity of the connective tissue and how this is a living system that's dependent on several different types of cell types, including immune cells such as macrophages and mast cells, operating within an extracellular matrix and interacting with other cell populations, including nerve fibers as well as adipose tissue. We know that there are several things that can influence the integrity of the connective tissue, including genetic factors, which was reviewed yesterday in a wonderful lecture. We know that there are environmental triggers that can also modify the connective tissue. This was touched upon yesterday by Dr. Oro when he talked about the role of diet. I can also extend that to airborne and contact chemicals, as well as climate change, and how this can influence the structural integrity of the connective tissue. And then I'd like to kind of lead into the role of the immune system in the maintenance of connective tissues and dealing with tissue injury and repair. So although Dr. Ehlers and Dr. Damlos first described various variants of connective tissue in the 19th and 20th century, we find that in 2017, a large consortium came together to kind of extend the types of variants that are been described for Ehlers-Danlos syndrome. And what I'd like to point out that although there are a lot of different types of proteins and enzymes that have been associated with the structural integrity of variant forms of connective tissue disorders, the more prevalent form of hypermobile Ehlers-Danlos syndrome and its variant hypermobile spectrum disorder, the genetic association has not been predetermined. And then, interestingly enough, a more recent form of Ehlers-Danlos syndrome called periodontal EDS, that is associated with mutations in the complement system, again, implicating the role of the immune system in predisposing individuals to developing certain forms of Ehlers-Danlos. So let's talk about what's going on in the tissue. So everyone talks about having a healthy immune system, but it really is all about balance. And there are lots of different proteins and cells that are responsible for recognizing tissue injury and responding to inflammation. And the focus has a tendency to focus on cells and proteins that are found in the blood, probably no different than cells or proteins that are found in the cerebrospinal fluid. But honestly, this is not a blood or a CSF issue, this is a tissue issue. And I'd like to talk about the one cell population that's starting to gain more attention given its close proximity to the connective tissue and its role that has been identified not only in humans, but in birds, fish, and originally in tadpoles and non-vertebrate species such as frogs. So mast cells are not classically found in the blood. They are associated with the connective tissue that's exposed to the environment, so they are uniquely positioned to recognize danger and respond to it with a plethora of chemicals, including histamine, chemical enzymes such as tryptase and chymase, mediators such as chemokines as well as cytokines. And there are programmed release of these chemicals depending on what the danger is determined to be or perceived to be, and then coordination of the tissue repair after the harm has been contained. So briefly going over mast cell biology 101, these cells are born in the bone marrow. They are released into the circulation as progenitor or immature cells. And they've been loosely described into three classes of mast cell variants. You have the ones that contain the enzyme chymase, which is primarily found in mast cells that are in the skin, the joints, the muscle, and the gastrointestinal submucosa. And then you also have the mast cells that only contain tryptase, and they're primarily found in the gastrointestinal tract, the lungs, and the sinuses. And these cells have lots of different receptors to try to recognize what they're seeing as a change in their surrounding microenvironment. And then depending on what they see, and they have the capacity to not only recognize physical trauma, foreign substances through either complement or immunoglobulin receptors, but they also respond to chemicals that are released by other cell populations as well. And then depending on what receptors are engaged, you have various chemicals that may be released either through secretion or wholesale, what we call degranulation. And even those granules, sometimes they're just released within the local microenvironment, and sometimes they are released in intact form and have the ability to travel to local lymph nodes and influence the adaptive immune system, such as the development of antibodies or T cells as well as B cells. So basically, the mast cells seem to be the first responders when it comes to cell injury. And then again, once the injuring substance or organism is contained, they help coordinate the repair. So to kind of give you an idea of the different receptors that are available, you have toll-like receptors, complement receptors, you have cortisol-releasing hormone, estrogen and progesterone receptors, and they have the capacity to respond to various pathogens such as bacteria, viruses, parasites, chemicals that, whether they're naturally occurring such as stinging insects or biting animals, or physical trauma such as burns, pressure, or penetrating trauma. And then depending on what receptors are engaged, you'll have various chemicals that are released, which may be able to contain any of these dangers on their own, or potentially call in help from the vasculature. This is the redness and heat that you might feel when you have an inflammatory response. And depending on what substance was perceived or microorganism was detected, you'll have recruitment of either eosinophils, T cells and B cells, macrophages, or other types of lymphocytes. So this is the type of trauma that they've been able to recognize. These are the chemicals that get released. Then once the wound is, the agent that caused the wound has been contained, the mast cells do have the ability to secrete factors to modify blood flow. They have heparin as well as platelet activating factor, and they also have the ability to release chemokines and cytokines that can call in substances such as, call in cell populations such as neutrophils or macrophages. And actually I would say that is this system that is primarily at work when dealing with coronavirus exposure. Having a effective innate immune response rather than adaptive immune response may be the key to tackling this COVID pandemic. So as with anything in the body, there is a plus and minus, and inflammation wants to be balanced. So too little, you can end up with increased susceptibility to infections or poor healing ability, or you might not be able to perform adequate surveillance for preventing cells that have acquired the ability to become tumors. But primarily, these cells are responsible for tissue defense as well as tissue repair. And the connection between connective tissue and mast cells has been long identified. This is a paper that I had unearthed back in 1977, which showed that individuals that either had Marfan's disease or variants of Ehlers-Danlos syndrome were at increased risk for having ATP, which is another way of saying allergies or allergen-driven inflammation. And to the right, this is one of the individuals who I've been testing who come through, and as an allergy immunology specialist, I now actively screen for connective tissue disorders because it seems that individuals that have this hypermobility have increased susceptibility to activating mast cells potentially inappropriately. Then in 2011, I found this paper talking about how there is an increased presence of mast cells that contain kinase in individuals that have what the Russian researchers here called undifferentiated connective tissue dysplasia. And in this report, they basically went into a cosmetic clinic and screened individuals for connective tissue disorders. And then they found that these individuals had an increased content of these kinase containing mast cells in the skin and joint. And just to let you know what kinase and tryptase do, a major researcher in the immunology world is Dr. Chiari, who has shown that these enzymes could be equated to what's called meat tenderizers. So they have the ability to clip collagen and modify the local environment to allow or accommodate inflammation, for instance. And then you move on to one of the major geneticists in the EDS world, Marco Castori, who identified in 2012 that individuals that have joint hypermobility syndrome, which we would now call hypermobile EDS or hypermobile spectrum disorder, that they were at increased risk for developing chronic pain syndromes, chronic fatigue, POTS or cardiovascular dysautonomia, pelvic dysfunction, even exocrine gland dysfunction such as thyroid disorders or adrenal dysfunction. And he cites that there's immune dysregulation, but did not go any further in identifying what might be the cells or proteins that are responsible for immune dysregulation in this patient population. And I'd like to argue that the mast cells, which are educated by the connective tissue on what they should or should not do, might be a prime candidate for understanding the immune dysregulation that we have identified in individuals that have these type of connective tissue disorders. And then to move up to more scientific evidence suggesting that in the EDS population, there has been the one mutation that has been associated with the development of hypermobile Ehlers-Danlos syndrome or hypermobile spectrum disorder. And rather than a mutation within the enzyme tryptase, these are individuals that have actually acquired increased copy number of this enzyme that's very potent. It has the ability to deactivate venom, whether you're talking from a poisonous African snake or a brown recluse spider. And in these individuals, which is an autosomal dominant inherited pattern, there was variable penetration of these symptoms, including irritable bowel syndrome, flushing, itch, or swelling, connective tissue abnormalities that would qualify for the diagnosis of hypermobile spectrum disorder, hypermobile type Ehlers-Danlos syndrome, and also orthostatic intolerance and dysfunction of both the central and peripheral nervous system. So I would argue that it would be worthwhile seeing whether you have mast cell dysfunction if you've been diagnosed with Chiari malformation, cervical spine instability, tethered cord, or actually have the diagnosis of EDS itself. And it's a very simple formula to try to identify whether you're having mast cell dysfunction or not. Do you have signs or symptoms that suggest that you have mast cells causing hypersensitivity reactions in at least 2 organ systems? Do you get better with medications that target mast cells or the mediators that are released by mast cells, such as histamine or leukotriene metabolites? And then, after getting a really good story, do you have test results that suggest that the mast cells are overactive or dysregulated? So, although this proposed criteria was put forth in 2015, the first major journal to talk about mast cell disorders outside of mastocytosis and allergies was this New England Journal article in 2015. And this is a busy slide, but I just want to emphasize that mast cells contain a lot of different types of active biomedical chemicals that can modify any organ system. And as was said yesterday, it's all about location, location, location. So if this is in the skin or the gut or the brain or the spleen, you have the ability to modify that organ based on how the mast cells are being engaged. So to kind of sum up again, what the diagnosis of mast cell activation syndrome is again, do you have episodic signs or symptoms? Do you respond to medications that quiet the mast cells or chemicals that the mast cells release? And then the last really focuses on what evidence do you have to suggest that your mast cells are overactive. There's some indirect evidence by detecting increased mediators either in the blood or the urine, such as histamine, or in the blood serum tryptase. But also, these are tissue-based cells. So there's something to be said about doing a biopsy of an infected organ to see whether or not the mast cells are chronically activated or not. To kind of go through some of the symptoms that have been identified in individuals that either have clonal mast cell disorders such as mastocytosis or non-clonal mast cell disorders such as the group at Brigham and Women's that looked at identifying mast cell dysfunction in IBS clinics, you can see that the major symptoms that these individuals were complaining about was itch, swelling and hives, and gastrointestinal distress. But the third most common phenomena that was identified in both of these patient populations was neuropsychiatric issues, mood disorders, brain fog, neurocognitive impairment. And so again, if you are been diagnosed with a neurological disorder and have evidence of a connective tissue disorder, it would be optimal to see whether or not your mast cells may be contributing to your symptoms or not. These are some of the medications that have been used to try to quiet mast cells down. The ones that have been used to help diagnose mast cell activation syndrome include histamine blockers, such as that found over the counter, such as Claritin or Benadryl, Pepcid or Tagamet. Interestingly enough, tricyclic agents, which were originally used, one of the first line for mood disorders, have been actively used by allergy immunology specialists for chronic urticaria, neurologists that have pain syndromes, for patients that have pain syndromes, and gastroenterologists who have IBS. You also have medications like Singulair and Zoflucas. These other interventions have been shown to be very helpful as well, but they are not mast cell specific. And lastly, This is a slide that's just showing you the various data that's available to identify whether or not your mast cells are overactive or dysfunctional. The one that's most sensitive without having such an invasive procedure such as a bone marrow or undergoing endoscopy or colonoscopy is just checking a serum tryptase. And just like you would look for a heart attack, a person that may have a heart attack and get serial measurements of cardiac enzymes, I would recommend the same for trying to identify somebody who may have a mast cell activation disorder. There's also urine metabolites such as histamine or leukotriene metabolites as well. And then if you have undergone an endoscopy or undergone surgery such as a repair of an occult tethered cord, which Dr. Klinger may discuss tomorrow's lecture, you can actually look for dysfunctional mast cells by staining for mast cells, which is not part of the traditional stain done by pathologists. And then after identifying the mast cells with CD17 markers or anti-tryptase antibodies, you want to see whether or not these cells are chronically activated by upregulating receptors such as CD25 or CD2, or to see whether or not these solitary sentinels are actually clustered, which would again indicate that you may have a mast cell activation disorder. So once you get a good story and you have data suggesting that your mast cells are misbehaving, it's also important to know that because mast cells talk to connective tissue, talk to nerve fibers, talk to endocrine organ systems, it's important to make sure that you're not missing another overlooked disorder that may be causing the same symptoms. So again, using these three criteria, it's important to understand whether or not you are having just a mast cell disorder, or is there something else potentially contributing to your constellation of pain syndromes, gastrointestinal distress, or chronic musculoskeletal involvement. This is a list of what I would call mast cell activation syndrome masqueraders. This is be part of my slide set, so I'm not going to dwell too much on this, but the one set of symptoms that I think would be important to distinguish whether this is mast cell or neuronal would be trying to understand whether you have a syndrome of dysautonomia. You can see that the symptoms that are associated with mast cell activation syndrome can also be associated with autonomic dysfunction as well. This is an adaptation from Satish Raj's review on symptoms that individuals that suffer with postural orthostatic tachycardia syndrome can present with. And again, because nerves and mast cells talk to each other, you can see how someone could have mast cell activation syndrome and also have orthostatic intolerance or manifestations of a peripheral neuropathy as well. Once you've gotten the diagnosis of mast cell activation disorder, it's really important to sort out whether or not you have a set of broken mast cells that are contributing to your symptoms, such as mastocytosis, or the mast cells are just being good soldiers following bad orders. The most common form that we're familiar with are individuals that have positive allergy tests identified by either skin testing or blood work. But you can see mast cells have lots of different other receptors, and if overstimulation or misstimulation by these extrinsic factors, you can also have chronic mast cell dysfunction contributing to neurological phenomena as well as structural issues with the connective tissue. This is a list of some of the tests that I typically do when individuals come through our practice for evaluation. Most people have had allergy tests, a good number of them. The allergy tests have been negative on numerous occasions. But again, mast cells are not a one-trick pony. They have the ability to recognize other immunoglobulins, complement. Estrogen and progesterone is not uncommon for women who are of childbearing years to have increased or decreased symptoms with the onset of their menstrual cycle. We have a huge number of patients who've come through for evaluation, up to 1,000 over the past 6 years. And interestingly enough, the biggest marker for mast cell dysfunction in these patients is actually unidentified primary immune deficiency. We also do screen for connective tissue disorders as well as neuropathic syndromes as well. This is kind of a list of the different forms of mast cell activation disorders. The most common, of course, are allergen-driven mast cell dysfunction, but you also have individuals that have primary immune deficiencies. They have autoimmune disorders such as neuropathies or rheumatological issues. And then you have individuals that have physical urticarias, like there is something wrong with the receptors either on the peripheral nerves or on the mast cells that are able to detect chemicals that are released by the peripheral nerves that can also cause mast cell aberrant activation. There is a smaller subset of individuals that have idiopathic anaphylaxis, and despite vigorous testing by the various centers, we still have not been able to identify why they're having such susceptibility to this systemic mast cell activation disorder. And then the least common would be individuals that have clonal mast cell disorders, either mastocytosis or a minor variant called monoclonal mast cell activation syndrome. And as I had alluded to before by the work by Jeffrey Lyons and Josh Milner at National Institutes of Health, there are individuals that actually have acquired increased numbers of tryptase copy, which leads to increased release of this very potent enzyme called hyperalpha-tryptasemia. So when it comes to treating individuals that have mast cell disorders in connection with connective tissue disorders and neuropathies, it all depends on what's causing the mast cells to misbehave. So as Dr. Oro had referred to yesterday, avoidance measures have been very effective in some minor cases of mast cell dysfunction. Changing your diet, whether you're talking a paleo diet, increasing your omega-3, 6 diet, or gluten avoidance. Also, we have, as much as we talk about eating, it's important to understand that you breathe 18 times per minute. The ongoing inflammation in the upper airway, as we've now seen with, for instance, coronavirus infection, can also cause neurological problems as well. We have the use of desensitization. We have several biologics now available to help calm down mast cells, as well as anti-interleukin monoclonal antibody biologics as well. For autoimmune disorders, as was referred to earlier in an excellent lecture talking about neuropathies associated with connective tissue disorders and Chiari malformation and peripheral neuropathies, we have the use of certain biologics, IVIG or subcutaneous gamma globulin administration, as well as several anti-inflammatory agents. Again, it's important to identify whether or not the mast cells are actually being called into action appropriately because you've had an undiagnosed infection such as hepatitis, HIV, Lyme, Borrelia, Epstein-Barr virus, or HSV. And then for individuals who have primary immune deficiencies, whether we're talking antibody deficiencies, decreased numbers of lymphocytes such as T cells and B cells, you have the use of prophylactic antibiotics or tailored probiotics. Fecal transplants is actually gaining traction in some centers as well. And again, you have the use of supplemental gamma globulin infusions. I just wanted to share some of the data that we have for mast cell activation. This is just a report showing that individuals that were coming in for complaints of hypersensitivity reactions was actually an undiagnosed primary immune deficiency. The biggest signal we've had up to this point is mannose binding lectin deficiency, but we've also identified individuals with idiopathic CD4 lymphocytopenia, as well as antibody deficiencies. This is showing that there have been increasing number of case reports linking hypermobile type Ehlers-Danlos syndrome with mast cell dysfunction, as well as neuropathic issues. And this is a really old study back from 1966 showing that individuals that were found to have connective tissue disorders have a tendency to have primary or secondary hypogammaglobulinemia. So one other treatment that I do want to talk about is then again the connection between the peripheral nervous system and the mast cell compartment. These are studies that have shown that vagal innervation has been able to help with quieting down irritable bowel syndrome, and also has been used for peripheral neuropathies as well. We have several patients that utilize traditional Chinese herbal therapy, as well as acupuncture and acupressure to help restore tolerance to their disorders. So I'd like to just finish up and say that mast cells play a key role in homeostasis with key roles with tissue defense, inflammation, management of blood flow, as well as reproduction. And that when you have a pain syndrome, a neuropathic issue, it's important to understand considerations of having a mast cell disorder because, for instance, with pain management, there's certain medications that will directly activate the mast cells and reduce the efficacy of the of pain management, as well as with anesthesia. We have an issue with tissue repair. So individuals that have connective tissue disorder who undergo surgeries such as cervical spine instability, there'll be considerations on the surgical procedure itself and also the healing that happens after the surgical procedure. So again, it's important to check for the possibility of a mast cell disorder contributing to a poor tissue repair. And then the last thing I wanted to talk about is the fact that individuals can be at risk for having fibrosis with overactive mast cells or dysregulated mast cells as well. So to finish up, I hope that this has been a journey similar to what happened to Neo in the Matrix. And when you take the blue pill, he turned it down, and I wanted to open your eyes to the fact that our bodies have organ systems that talk to each other all the time. And if there's miscommunication, there's at risk for pathology, and that a forgotten mast cell, that growing evidence is now showing that mast cells do play a key role in management of tissue repair, as well as tissue defense and homeostasis as well. And I want to thank you for your attention. And I'll also reach out to ASAP and again appreciate this wonderful invitation to talk about how the immune system may be contributing to some of the patient's symptoms who are attending this conference. Thank you.